Dr. Sobhi, Dr. Colombo, thank you very much for inviting me. I would like to do some change because all the cases were hectic. So this case is a 57 years old diabetic patient. On the last June, he admitted to the CCU in another country with non-ST elevation myocardial infarction. His echo revealed posterolateral and inferior hypokinesia. And they did coronary angio there and revealed 3-vessel disease and has been advised for urgent CABG. The patient heard that he has to go for urgent CABG. On the same day, he had syncopal attack, brain CT, revealed hemorrhagic infarction, and fissure fracture of the skull. On the same day also, he developed hematemesis. And endoscopy revealed gastric and duodenal ulcer, and they postponed CABG for 2 months and given medical treatment. This is the CT on the same day, and after 1 month, it was okay. Then the patient, this is the endoscopy on the same day, and the patient came in the emergency from the airport, and we admitted him to the CCU, and we have done for him endoscopy, and it revealed that he has completely healed duodenal ulcer with evidence of hemoclips still in place, but it's okay. We asked the endoscopist, can we do something for him? He said, okay, go, and I told him I can give antiplatelets. He said, okay. So this is his coronary angio. It showed proximal LAD. It's not actually proximal. It's after the first diagonal, so it's in between mid and proximal. And the LAD is tight lesion in this area, and the diagonal branch also have a tight lesion, 80%. The rest of the LAD is diffusely diseased, lot of lesion, and the LCX is totally occluded, and the right coronary totally occluded, and both receiving collaterals from the LAD. You can see also now the right coronary. This right coronary is totally occluded, and the LCX is totally occluded, and both receiving collaterals from the LAD. Then what to do? Continue medical treatment, PCI or CABG? The panel. No, this is we did it. We did it here because his angio was not clearly seen, and I saw his angio, and I said that for me and for other cardiologists in the same department, they said that it's actually not for CABG. Why did they say that this patient is for CABG? So, and the views were not perfect. So I did an angio, and we left the patient for another day to take the decisions of others what to do. What to do?
And how was the patient neurologically?
He's okay. There is no lateralization. You have seen the CT after. He had a CT 1 month after. Okay. I show you.
So at that time, when were you from the event of hemorrhagic stroke?
1 month.
1 month. And the patient didn't have chest pain?
He came in unstable angina. He came in with emergency car from the airport. Medical treatment in a patient unstable angina and he had non-ST elevation myocardial infarction. Okay, our case scenario and problem, the LAD is diffusely diseased with multiple lesions and areas of calcification, and the possible site of the graft had a very tight lesion. And we have diagonal stenosis, we have totally occluded LCX, and we have totally occluded right coronary. The patient had stroke, and the post-CABG, in comparison to post-PCI in recent literature, stroke post-CABG was higher. Also, he is symptomatic. He is unstable angina. Oh yes, I know that his syntax score is 36, and he is diabetic, and his diabetes is controlled on oral therapy. And what about that? Would you give what? Would you give Plavix? Would you give Brilic? Would you give what? Excellent. Thank you very much. So most of you like to do PCI or CABG? Who's, okay, fine.
I think this patient with extensive coronary artery disease is going to respond this for UTP, at least in the first 6 months. Don't get dual antibiotic. Just stabilize the patient. This patient has excellent ischemic deconditioning. I think so. So I think it's going to respond very well on medical treatment, at least in the first few months. If it's not responding towards and then proceed to PCI.
Who
will go for medical treatment? 35. Who go for CABG?
ليه قلتي كابج؟ انا ما سمعتش، انا مش فاهم حضرتك قلتي ايه. بس هو خلاص، ما هو بس يعني انتوا ازاي بتتكلموا على ميديكال تريتمنت والبيشنت انستيبل انجينا، والعيان جاله قبل كده 1 month before non-ST elevation myocardial infarction. What do you want for medical therapy to do for this patient? Okay. So yes. Okay. But I would like to have the Colombo. I go direct? You don't want me to take his opinion? Okay. So, what to do type? And you have these vessels. Would you prefer radial or femoral approach? Which artery you start with, RCA, LAD, or others? What is your strategy if you start with this artery, which you will start with? What guide you prefer? Which wire to start with? Will you use microcasters? Will you use drug-eluting balloon? ولا لا؟ قول لي بقى. Any other idea? Okay, I will show you what I did. I started with the wrong artery. The patient is having a good left main and proximal LAD, and he has a proximal lesion, and the distal part is a lot of lesions, as you said. My strategy is to do a drug-eluting balloon for the distal part of the LAD, and then to put a stent in the proximal part. And this was wrong, but I did it. So we will go together and we will see. So I modified the lesions with balloon, and then I went with the drug-eluting balloon, 40 millimeter, and I dilated the distal part of the artery. And then this is the drug-eluting balloon. And To put the stent, I have to see the origin of the diagonal branch. So we did an angio, and we did the spider view afterwards, and we know where to go. So I went with the stent in the tight stenosis of the LAD, and I deployed the stent there in the this area, and then after that I would like to go to the diagonal branch. And to go to the diagonal branch with the wire in the LAD, I tried many times to go, but I failed. So I took the wire from the LAD, I went to the diagonal branch, and I put the stent there. I fixed the stent properly. You will see how to fix the stent properly in this diagonal branch. And you will see what problems happened after. So this is the stent in the diagonal branch, and it was okay, but you can see the LAD. Do you see the LAD? There is something. So I said that this is spasm. We gave Trideal, and then also we went with a balloon and dilated the area, and it was okay. So I said I go quickly to the other occluded arteries. So I went to the LCX, and I opened the LCX, as you can see here, and we put, excuse me, you are talking to, what's the problem? We have two stents in that artery, and this was a completely occluded vessel, and this was the result of the LCX, and the wire I have in this case not easy wire or for example the usual wires. No, you have to go with the choice PT. So we went here to that area of the LAD, and it has a dissection. So we wanted to seal the dissection, and in the same time we went to the right coronary and opened the right coronary, and we left the balloon in the LAD to seal the dissection. This is if you put this balloon in the LAD and you are opening the balloon 2 to 4 atmosphere, it's nothing. It will not cause any problem to the LAD. Yes. Huh? Yes. The right coronary is occluded artery. I'm opening the occluded artery. I have an LCX opened, and the LAD I'm having a dissection in. I want to seal the dissection. Yes, I finished the LAD, but I put a balloon now. Yes, in the same time, both. I put the balloon to seal the LAD, to seal the dissection in the LAD, and I opened the right coronary. And you see now the right coronary is okay, and the LCX is okay. And here it's not sealed, the dissection, so I have to go with a stent in the LAD to seal this dissection. And I sealed this dissection. It's a hectic case. This is the LAD after doing that, and the RCA. It's nothing. It's not important. He's stable. Patient is stable, and you have this. So we have all the vessels opened. We have an opened CTO of the LCX and CTO of the RCA. حبيبي. I have, but the scenario is that ما خدتش بالك؟ أقول لك. The problem is now we have I dilated the LED with the drug eluting balloon. يا جماعة استنوا لأنه بيسأل سؤال مهم. I dilated with the drug eluting balloon. الدرج أيوة I have. اوكي انا هقول لك هقول لك بعدين. اوكي طيب last slide ده خلاص. and could it be other way؟ احسن حاجه. طيب the decision after قرار. ميرسي. Thank you very much. أنا شايف إن دي is very good يعني. Thank you very much. You are right. You are right. But I did that and it was wrong. I know. But I will do afterwards the right. I will start with the right. Thank you very much.